Hi, welcome back to Nurse Ed Scholar, and today we're on lesson 4 of the Cardiac Priority series. Today we're going to be talking about dysrhythmia basics, stability over memorization. So let's start. If you see a rhythm strip on the NCLEX and immediately panic, you know, realize you're thinking the wrong way. The exam really isn't asking what is the rhythm called. It's asking, is the patient stable or unstable? Because unstable rhythms kill your patients, and stable rhythms actually can be managed. So today, I'm going to discuss how to answer dysrhythmia questions without memorizing every strip. So, what does the NCLEX actually test? Okay, so the NCLEX tests oxygenation, perfusion, hemodynamic stability, and what's the next best action? Okay, it rarely tests, what's a detailed waveform interpretation or the exact name of a rhythm unless it's going to change the treatment. The most important question is, does the rhythm compromise cardiac output? Because rhythm only matters if it affects perfusion. Okay. So, what makes a rhythm unstable? So, a rhythm becomes unstable, it becomes dangerous when it causes hypotension, chest pain, altered mental status, signs of shock. So, that's that cool, clammy skin. Um, uh, decrease urine output. Okay, so acute heart failure and syncope. These are the clues that you're going to be looking for. Not really the key wave or the PR interval. The symptoms really tell you the danger that the patient is experiencing. If the rhythm is unstable, then it's immediate intervention. But if the rhythm is stable, you're gonna move a little bit slower and you're gonna start medication-based management. Okay. Now, looking at, rhythms, instead of memorizing, 20 rhythms, just kind of put them in four categories. So, number one is the ones that are too slow. So that's bradycardia. Number two would be the ones that are too fast, tachycardia. Number three, the ones that aren't organized, so like your ventricular fibrillation. And then number four, it's those where the electrical activity is without perfusion. And that acronym, is PEA. And that's really it. Look at it in those four rhythm categories. So when you're thinking bradycardia, we know bradycardia is where a heart rate is less than 60. If the patient is asymptomatic, you just monitor them. Okay. If the patient's symptomatic, so like if their blood pressure is also low and they're having dizziness, then you're going to be expecting an order for atropine. Okay. You're going to notify your doctor and you're going to expect an order for atropine. With tachycardia, you're going to think, okay, is the patient stable? Because if the patient is stable, you're going to be looking for orders for medications like your beta blockers or even adenosine, depending on the type of tachycardia. And if the patient is unstable, if they have an unstable tachycardia, then you're expecting synchronized cardioversion. Now, with your ventricular fibrillation, the patient doesn't have a pulse. So if they don't have a pulse, then nothing's being perfused. And if nothing's being perfused, you're going to need immediate defibrillation. Okay. It's time sensitive, no perfusion, the organs are not getting any blood, no oxygen. So immediate defibrillation. And when you're looking at PEA, pulseless electrical activity, and asystole, there's a rhythm on the monitor, but there's no pulse. And so with those types of patients, you start CPR, EMS is going to arrive, rapid response. They're going to have a code card. They're going to start epi. But remember, with pulseless electrical activity, PEA and asystole, you do not shock that flatline rhythm. Okay? You know, um, and that's the trap. The trap is going to be, students are going to choose to shock asystole or PEA. Just remember, you do not shock a flatline rhythm. Okay, let's move on. Now, you know, when you're thinking of dysrhythmias and stuff, you kind of think of it like, okay, so how am I going to frame this? What am I going to do when I see a dysrhythmia? What are the steps? And so, step one, you're going to check the pulse. Step two, you're going to check the blood pressure. We always talk about getting vital signs, right? Step three is you're going to assess the patient's mental status. Are they alert? And then four, determine if perfusion is adequate. So if there's a pulse and stable vital signs, it's a stable rhythm, med management. That's what you're going to anticipate. If there's no pulse, then immediate CPR and defibrillation if there is a shockable rhythm. And if there's a pulse, but the patient is unstable, then you're going to anticipate synchronized cardioversion. Okay. The intervention is based on the stability of your patient. So let's look at some mini scenarios. Okay. All right. Number one, your patient has SVT, supraventricular tachycardia. Their heart rate's 180, the blood pressure is 120 over 70, and they're alert. So they're stable. So that would be a stable tachycardia. And so, what are your next steps? You may tell the patient to do some vagal maneuvers, or you're going to anticipate some adenosine from your primary care provider. Number two, you have a patient, their heart rate is 180, their blood pressure is 70 over 40, and they're confused. So your patient is unstable. This patient has unstable tachycardia. So the next step is going to be synchronized cardioversion. Number three, your patient has AFib and no pulse. They are unstable, immediate defibrillation. And then last, number four, your patient flatline, no pulse. You're going to immediately start CPR. You're, waiting for the code card to give some epinephrine. You do not shock the patient. You do not shock a flatline or a patient that has uh, no pulse. Okay. And we're gonna, I put this back in to review that decision tree again. You have a dysrhythmia. What do I do? So first, you're gonna say, does the patient have a pulse? If no, CPR. And if they have VFib or VTAP, you're going to shock the patient. All righty. If the patient has a pulse, are they stable? Unstable, you would do synchronized cardioversion. If the patient is stable, you're anticipating medication management. And that's the logic of the NCLEX. Okay. I hope this kind of helps you out some. And that's really it. you know um so if dysrhythmias, if they overwhelmed you, and hopefully this video kind of helps simplify it some, please put stability first in the comment section. The next video of this cardiac series, I'm going to do hemodynamic simplified. So we're going to go over map, we're going to go over preload, we're going to go over afterload. So, to kind of reduce some of that panic and that confusion that you're having. And so if you like this video, if you've liked the video series or other videos, please subscribe to Nurse Ed Scholar. Hit that like button. Go to nurseedscholar.com. I'm creating workbooks to help you study uh, in nursing school. And all of this is really to, educate as many nursing students as I possibly can to help you study smarter so you can test like a pro. And so until next time, happy studying from Nurse Ed Scholar.